All right, guys, we're gonna do a selfie together first. Hold on, because we're a family, right? Okay, here we go. All right, everybody take these. There you go. We'll post that later. All right, where are we? Right in front of us. So this is the keynote. So what is the function of a keynote? It's kind of to set the tone, to give you some facts, some ideas, some concepts, to either for the key opinion leaders or you to discuss, disagree with, agree with, whatever. And it's also allowing me to give a shout out to some of the things that you're going to see during the rest of the day and tomorrow too. So disclosures, I've consulted for almost every drug company you can think of. I was thinking about this the other day, that it's probably better to have multiple disclosures than just one. It's a bit like, if you get drunk and you propose marriage to 50 people, it's more excusable than if you propose to just one that you regret the next day. So I don't have a favorite, and they keep coming back to me, hopefully, because I keep telling them the truth. I called the keynote right in front of us, and the first thing is, because this is the first technical talk, I'm going to give you a couple of slides just on some of the technical terms we tend to throw around, especially for those, this is a diverse audience. Some people may not even know what a clinical trial is. Other people may be able to quote the p-value for the hazard ratio in a randomized phase 3. So we'll give you some basics, and then we'll get into the meat of it. So right in front of us, in terms of what we already have going on, the tools that we currently have to actually get you living your best life. And then also right in front of us in the sense that the questions to ask, some of them are really obvious, but they're right in front of us and sometimes we miss them. And I'm going to draw the analogy with those hidden picture games where it's kind of like it's sitting there and you go, I can't see it. And someone goes, oh, it's negative space, it's there. Okay, you'll see. All right, so quick translation tool. We're all nerds here, well, at least on this side. So what do we talk about? Well, we tend to show these things. These are called Kaplan-Meier curves. And what they are is they're a time to event. So on the x-axis, the thing on the bottom, that's the time. And on the y-axis, the thing going up, that's the event. So that can be the time to dying, it can be the time to your cancer progressing, it can be the time to, whatever you want. This is one of the more famous and slightly depressing figures from nearly a quarter of a century ago. And this was the overall survival plot for people with lung cancer, not otherwise specified, getting 4 different types of chemotherapy. And the way these plots work is everybody starts at 100%, nobody's died. And then over time, as an event, in this case a death, happens, you take a step down. And so the worse your treatment, the quicker that staircase goes down, and the better the treatment, the more it hits a kind of landing. And you can see it looks pretty depressing. We tend to describe those curves either as an event, so if you look on the bottom, those are months. So the 1-year survival rate 25 years ago at 12 months, so if you took 10 and then a little bit further on and you went up, that's about 33%. That's pretty depressing. I mean, that's almost as bad as Kirk's figure. It was like your chance of being alive a year afterwards was a third. And the other way we describe it is we take the 50% point on the y-axis, on the survival axis, and we draw a line across until it hits the curves, and that's called the median. That's the 50% point when 50% of people will have had an event and 50% of people won't. And in that figure, it was about 8 months. Don't worry. That's like describing, cars that run with a horse in front of them. I mean, just, it's the past. The other thing you'll see are these kind of things, and they're called waterfall plots because they look a little bit like a waterfall. And this is about how much a cancer shrinks on therapy. Each one of those bars is an individual patient, and in particular, they're taking select deposits of the cancer in that patient, adding them up, and that's your baseline. Then you go on the treatment, and then the percentage change in that, either increase or decrease, is what's plotted on this figure. How do they choose which let's say you have 50 deposits of cancer, how do they choose which ones to measure? Well, they have to be a big enough size, because it's really hard to measure a teeny thing accurately. They have to have nice clear edges, so pleural effusions and things like that don't appear as target lesions. And then we put them into little categories. So the objective response or response rate is the proportion of people whose cancers shrink by more than 30%. So if I say an 80% response rate, it doesn't mean my cancer shrinks 80%. It means 80% of people are in the same boat as me, and we've had shrinkage by at least 30%. For slightly weird reasons, if it completely disappears, that's called a complete response, although lymph nodes have got their own rules. And then everything in between, so is stable disease. You can see it's color-coded differently. And you can see that's a mixture of people with a little bit of growth, a little bit of shrinkage. And that's why most clinicians are a little skeptical of stable disease, because really the important thing there is how long it lasts for. You know, if you do the first scan and it hasn't shrunk, am I optimistic? Am I pessimistic? It depends on whether it's a little bit of shrinkage and there's going to be more coming, or a little bit of growth, in which case I think this is going to be a short honeymoon. And then you can see that red is, you know, your best response on that first scan is progression, and that means growth by more than 20%. So you can see these are completely arbitrary terms, but that's the terminology we use so that two physicians talking about the same data set know what they're talking about. All right, now you're experts. Right in front of us, the future is now. So we're going to jump straight in. This is the study of Pfizer's lorlatinib as the first-line treatment versus Pfizer's crizotinib. It's kind of internecine battle at Pfizer. And this was the data that was presented in June. This is the CROWN study. And this is the progression-free survival, so the time it takes for the cancer to grow. And you can see that the lorlatinib arm is doing pretty well, and more importantly, that staircase is hitting a landing. It's hitting a plateau where it's not progressing. And that looks pretty good. But it is not the only drug with a plateau. This is alectinib versus crizotinib in the purple line. It also hits a plateau. And indeed, even here, crizotinib has a plateau. So there are some people who just have really dumb cancers. They cannot figure out how to get around the drug, and presumably they're tolerating it well, and they're doing great. So this is to set up the stage for when Ken asks us in the key opinion leader panel, if you're on alectinib or brigatinib or crizotinib, and the data comes out about CROWN, should you switch? Well, my take is it depends on where you are. If you're in the plateau, if you're a Kirk or a Nancy and you're out multiple years, you're doing good. You're doing good. You don't need to change anything. Maybe we don't know why, but, you don't need to change it. I got that one from my daughters. So I think we start to realize, and we threw out this term a few years ago, the idea of GALKs and BALKs, good ALKs and bad ALKs. So the good ALKs are the ones who are in the plateau. And the bad ALKs, so they're doing great. The bad ALKs are the ones who are progressing before the plateau. And it varies depending on which drug you're on. At the moment, most of our reaction is we know you're a bad ALK when you progress. And then we're sort of reactively rebiopsying, figuring out what to do. What we'd really like to do is understand who's going to be a bad ALK up front, predict it, and then intervene proactively. We are not there yet. So really, the concept about which drug do you start on is about your chances of being in that plateau. So lorlatinib, the chances of being that plateau are higher than with other drugs. Why? Because it's just a better drug. Guys, we're scientists. Okay? Well, one argument, it does something very special in the brain and protects the brain from new deposits. I'm not going to go into that. Maybe we can bring it up later. But I truly believe there's something about lorlatinib that protects the brain more than other drugs. And perhaps the easiest pitch to explain is that it has broader activity against some of the resistance mutations you can get on the other drug, which occur in ALK. So you start off with ALK, and then you get additional mutations in ALK, which make it resistant to some drugs. Now you can model that in vitro. This actually came, I think, from Mass General, but Christine Lovely's lab and others do very similar work. You take the mutation, you can engineer it in cells, or you can put it in an isolated assay, and then you put on different drugs, and you see what concentration of drugs you need, in this case, to stop the signaling going on in ALK. And the color coding is completely arbitrary, and usually it's arranged so that whatever drug is sponsoring your study has most green. But I don't know if I can show it to you, but if you really want, I don't think I've got a pointer, but if you really want to know Look in lorlatinib, and about halfway down, just after halfway, it says 49.9, okay? And that's colored green because less than 50 is green. And then look at the second column in for ceritinib, about 4 up from the bottom, and that's 50.1. And that's colored yellow. Do you really think that's different? No, it's because this is sponsored by Pfizer, so we've got to make the cut point where the green is. All right, but the point being that there are different mutations which have a sort of Achilles heels for these different drugs, and there are fewer Achilles heels for lorlatinib. The other thing you have to factor in here is this is the concentration, and none of that matters depending on the exposure you can see in your body. Okay? If you can achieve, 5,000 nanomolar, then it doesn't really matter. All right, this was actually the waterfall plot I showed you earlier. This is actually the chances of shrinkage of your cancer if you get lorlatinib after you've had alectinib or crizotinib or ceritinib, and I think a few brigatinib patients in there. And about 40% of the patients hit that objective response level, so they had more than 30% shrinkage. You go, that's great. So lorlatinib is a second-line drug. About 40% of people will, quote-unquote, respond to it. This is where I want you to start to think about right in front of you. The real question is, why? We don't just accept that 40% as just a fact. The question is, why? And the answer is because that's the rate, roughly, with which these on-target resistance mutations occur, which lorlatinib can hit. There's no magic here. It works in the people who have that resistance mechanism. You can see the color coding here, that G1202R is called out in red, but the other colored areas except for the gray are resistance mutations that occur in biopsies. This is nice data from Mass General on crizotinib, ceritinib, alectinib, and brigatinib. So if you put all of those together, about 40% of people have a mutation that lorlatinib can work on, right? And people show this, and they say that's great, and the color coding is in color, and we're all very excited about it. But again, look at what's right in front of you. What is the elephant in the room? Well, elephants are gray. It's that area. The patients that don't have an on-target ALK mutation.
Check 1, 2. Hey, check. Let's see, that's
check 3. And the key thing is when you acquire resistance, it's not all about ALK. Sometimes there's ALK and something else. And so sometimes ALK has a friend. Now there's a partnership. ALK and another driver, the sort of things that have other advocacy organizations, EGFR, ROS1, MET, all of these other things can function as second drivers. And you can see that even with the latest drug. This is Nuvalent 655, which is a very good drug. It gets into the brain, it has less of the side effects of lorlatinib, and it works on some mutations that even lorlatinib can't work on. But you can see from this data that Jessica Lin presented last year that on the right-hand side, if you rebiopsy and you find you've got a resistance mutation, the Nuvalent drug has about a 50% chance of working. But if you look on the left, if you don't have a mutation, or more specifically, if you don't have a known mutation, which could be you tested and you didn't find it or you didn't test, there's only half the chance of working. Again, a lot of these people have got another mechanism resistance, and changing ALK inhibitor isn't always the answer. One of the most common second drivers is MET, mostly through amplification of the gene, but occasionally through fusions, occasionally through mutations in MET, and we just published this of when you stay on your parent TKI, the drug you started on, you develop MET as the mechanism of resistance, and you add in a MET inhibitor, another pill. It's a pretty good response rate. Something like 70% of people will have shrinkage, although the duration of that benefit is still relatively limited, about 5 months. But it's actionable, and again, there'll be a tail on that too. So one of the things that I think is at the edge of where we're looking at is how do we make MET alterations as a second driver actionable? How do we make MET meet its end? So the tyrosine kinase inhibitors shut up the signaling. That's on the left-hand side. They're kind of gagging the MET and saying, okay, well, now you're not functioning as a second driver. But we can also use MET as a means of delivering a poison. And so I think these drugs are going to be really interesting in the future. These are called antibody-drug conjugates. They're essentially a Trojan horse. So this is an antibody, in this case, with this drug Teliso-V, directed against MET, and it's got a really powerful chemotherapy attached to it. And, they're developing this in a whole bunch of people with MET protein expression, where it works in about 20 to 30% of people. But this data, which was buried in some presentation in Japan, is really interesting. It's not a perfect data set, but amongst the people who have MET amplification, one of those mechanisms of resistance, the response rate to this drug is 80%. So I think amplification of a gene, which happens to be a mechanism of acquired resistance in ALK and many other driver subtypes of oncology, is going to introduce a vulnerability to these antibody-drug conjugates. And those studies are ongoing. We really need to see not just the response rate, but the duration of that benefit. We need to confirm whether you need to keep that parent TKI going, let's say the alectinib or lorlatinib or whatever, and how tolerable that is. And we need in the future to think, given that the chemo you attach in these things can be variable, we have multiple lines of therapy with this option if MET remains a vulnerability. So that's where the next wave is going to come. The other thing we talked about is those bad ALKs and predicting them in advance. What you might call the speciation of BALKs, because not everybody develops resistance in the same mechanism. If you think about a pathologist, they look down a microscope and we're asking them to pick out, 1 in a million cells that will later be the mechanism resistance which is selected out. And that's super hard for the human eye to do that. But I'm hopeful that artificial intelligence, which is moving into pathology at a rate of knots, might actually help. This is a company called Imagene, which has developed, literally just looks at the slide, no molecular testing, and it predicts whether an ALK or a ROS1 is there in this data set with 100% sensitivity and specificity, completely replacing the pathologist. What if we were able to feed in the information of those people who later turn out to have BALKs as opposed to GALKs and see if it could predict that? That, to me, is something very interesting in the future. So to summarize my part one, how am I doing for time? Some people are doing great. I would argue don't mess with that. But BALKs are real. Mostly we're being reactive in our current model. That reactivity is not just about ALK mutations, though. We're learning new treatments for second drivers. And of course, it's not going to be all about second drivers. There's going to be some of that gray stuff, which we still don't even know yet. And I hope in the future we'll be able to predict and speciate different BALKs before you even start your first-line therapy. Okay, part two, right in front of us. This is about saying, what is the immediate research question which is staring us in the face and we may not have even noticed? So, again, I'm going to set this up for the key opinion leaders to kick around later. What is the function of anti-cancer therapy? Dude, you're an idiot. It's obviously to stop the cancer growing. It's to shrink the cancer. Well, maybe, but maybe it's also to minimize diversity in the cancer. That's what I'm going to put out there. And what I mean by that is diversity in the workplace is probably a great thing. Diversity in your cancer is a really bad thing. Look at things like the dodo and the panda. Not a lot of diversity, completely addicted to eating bamboo shoots or whatever pandas do. Really small evolutionary niche, super easy to become extinct. Got no adaptability. Compare that to, locusts here. Like, it's gazillions of them, and they can just adapt, and you spray a weed killer on it or an insecticide, and they'll still keep coming back. So evolution is cancer's best defense against whatever we throw at it. It will introduce diversity, and then you will select out the variant that can survive. And the more variants you have, the harder it is to keep the genie still in the bottle. So if you have that in your head, and you think about some of the recent developments, it becomes easier to think about. So this is a sideways move. This is FLAURA2, which is in EGFR mutant lung cancer, not ALK. This was a recent study that read out where everybody starts on a pill, osimertinib, that's the equivalent of an ALK inhibitor for EGFR mutant. And this study randomized people to that or that plus chemotherapy from day one. And it doubled essentially doubled the progression-free survival from something like 16 months to 25 months. Can't do the math in my head, not quite doubled. But you've got the toxicity of chemotherapy, and there have been real challenges with uptake. And lots of debates by AstraZeneca, who make osimertinib, to trying to figure out who they should give it to and who's high risk and who isn't. And for the clinicians, it's really difficult on day one to say, you've got a mutation, here's a pill, but let's talk about chemotherapy, and it's on day one. But think differently. What if the function of these consolidation approaches, deepening the benefit by adding chemotherapy, is just a means to reduce diversity, and even more, it's actually a bridge to some other step to reduce diversity. And by that, I mean consolidation radiation therapy. So the concept of going on a treatment, doing as best as you can with the drug, and then hitting what remains with radiation therapy really came about from this study. And Kyle Rostoven was a radiation oncology trainee with us, and he came to me and he said, I've got this crazy idea. I want you to take all the patients who had chemotherapy, so this isn't ALK, this is just lung cancer in general, and then we'll look at all of the scans. And when they get to the maximum response, the maximum amount of shrinkage, I'm going to then say, could I, in theory, because this is all retrospective, have zapped it with radiotherapy? And then of the group that I could have zapped with radiotherapy and the group that I couldn't, again, nobody's had any additional radiotherapy here, it's just in theory, we follow them up. Do they tend to progress where the cancer was, i.e. the radiation could have taken control of it, or in a brand new site? And the vast majority of progression, when you start on a treatment, is where the cancer already is. And if you think about it, it makes sense, because that's where there are most cells, that's where there's most diversity. So that theoretical idea was then taken up by MD Anderson in collaboration with ourselves in London, Ontario, and actually did a randomized study. Again, not selected for any particular subtype of lung cancer, but you either did or didn't get consolidation radiation at the maximum response to whatever your initial treatment was. And that's the darker line here, and it was a really dramatic effect on both survival and progression-free survival. And so for me, these consolidation approaches, like adding in chemotherapy, is a bridge to getting you to consolidation radiation. And why am I doing consolidation radiation? Because I'm trying to eliminate diversity. I'm trying to get rid of as much cancer at the beginning as possible. So what don't we know? What are the limits of the approach? How many sites can you actually zap? What do you do with your targeted therapy when you're getting that radiation? We keep it going. Radiation oncologists are trained to either believe that it's not safe until proven otherwise. We tend to adopt the model that it's safe until proven otherwise. And so far we haven't killed anyone, but you have to have that discussion every time. What about in the brain? In the brain, there's a suspicion that you could get this thing called radiation necrosis if you keep the inhibitor going. That's something we're still working on. Are ways of deepening that maximum response, like the adding in chemotherapy, just ways of getting more people to a state when you can do consolidation radiation? You want your target to be as small as possible. When do you add in that chemotherapy? Do you have to do it on day one, like the FLORA study? Or can you start on the TKI, be on it, get to your first scan, and then say, okay, you're doing well. Let's push it even further by adding in chemotherapy. That's what I do. I also don't keep the chemotherapy going long term. I want to get people to the radiation treatment and then say, okay, you can just stay on the pill thereafter. And then the last thing that's right in front of us is one particular chemotherapy, pemetrexed, has very specific activity, exaggerated activity in both ALK and ROS1. And the trouble is that was developed 30, 40 years ago, so nobody's researching it. But why? Why is pemetrexed, or Alimta, this standout drug for ALK positive? This goes back to 2011, we first published this. This is EGFR mutant, KRAS, ALK, and what we naively called triple negative at that point, lung cancer. And the bars are how long you stayed on pemetrexed. And you can see that the building, as it were, lying on its side, is much taller for ALK and much more uniform. So ALK always has this exaggerated sensitivity. You could see it even in the randomized studies of crizotinib versus chemotherapy. The yellow line is standard chemotherapy called docetaxel, but the orange line is standard chemotherapy with that pemetrexed, and you can see it's got that plateau. Pemetrexed in some people is an amazing targeted therapy, and we still don't understand why or who those people are. This was with ceritinib, and ceritinib is the blue line, pemetrexed is the red. Again, you can see that plateau there. All right, next question. What is the function of on-therapy surveillance? You're on whatever treatment you're on. Dude, it's obvious. It's to say when the treatment's not working. You go, is it? Or is it to capture progression when it's still suitable for local ablation? So more than 10 years ago, we published that so-called oligo progression, small number of sites progressing, whilst everything else is controlled, could be zapped with radiotherapy and you can keep the drug going. We called it weeding the garden. What's it doing? It's helping to minimize that diversity. The weed comes up, we don't let it spread, send its little diverse children around, we zap it. So if that's true, if the function of surveillance in the modern world is actually to capture progression when it's oligo as opposed to widespread, what is the best way to do that? Well, outside of the brain, is that just a CT scan? Is it you wait till you see something on the CT scan, then you do a PET to confirm that it's oligo? You'd be surprised how many people just do a CT scan, see only one site, and zap it with radiotherapy, when in reality there could be 50 sites that they haven't seen. Is it about doing a time-based PET, like once a year, once every 6 months, once every 2 years, whatever? Or is it about doing an event-based PET, where something triggers you, a screening test to do the PET, which might be a better health economic use of PETs, and also raises your pre-test probability that if you see something on the PET, that it's real. And this is mostly for Dr. Lamb to throw rocks at me for, but I use serum tumor markers for this. So every time you get a CT scan, I don't do time-based PETs. I run these blood tests, CEA, CA125, CA199, CA2729. I'm going to give you an example. This is CEA in a patient starting on, I don't know, alectinib. You can see it comes down, great response. Their scans look fine, but by tracking the markers, you can see that they start to trend up. You have to have a trend. Single reading doesn't mean anything. And that's the sort of thing that in my clinic says, the CT is missing something, we need a PET. So I do a PET, and there's a tiny deposit in the left hip that you would never have seen on a CT scan. So we zap it with radiotherapy, and the marker goes down. Now, this is where my colleagues can say, yeah, marker goes down, and how does the patient do? Does it make any difference? And I don't know. But it's kind of like, it makes intuitive sense to me that if I want to control the diversity in the cancer, I want to catch progression when it's an early stage of progression and treat it aggressively. What about going even earlier in the diversity game? Persisters. So the radiation consolidation approach is if you like, a way of treating persisting cells, cells which are still alive despite your treatment. But a persisting cell is essentially a concept of a cell that's not actively growing, but not actively dying. It's like hurdle the turtle here in the kind of, duck and cover sort of idea, that the cancer goes into this kind of siege mode and just sits there. And whilst we zap it with radiotherapy, wouldn't it be awesome, because I can't see everything on a scan, wouldn't it be awesome if there was actually a marker for that state and then we could direct a treatment towards it? And that's where the breakthrough cancer comes in, and so that's just my shout out, that they'll be talking about markers for persistent cells and how they can target them. And in that same category, that's where the vaccine approaches are being explored to try and get the death rate for the cancer from 99 to 100%. And finally, in terms of the things which are right in front of us, that we, and by we I mean everyone in this room and at home, can start to think about, is some of the ways we're dealing with cancer. So the beauty, I was talking to Dr. Ged Giel, where you saw that picture of the chemotherapy from 25 years ago, and now we're in a room where you say how many people are 6 years out, 7 years out, 8 years, and half the room stands up. It's mind-blowing and incredibly satisfying to us as physicians. But as we improve our appetite for benefit, we have to improve our appetite for giving normality back to people on treatment. So we have to remember that there's always a person attached to the cancer, that efficacy isn't just about the cancer shrinking, that there's also a family and friends attached to the cancer, as Nancy already mentioned. So I'm going to come back to the lorlatinib issue. So when the lorlatinib data first came out, it was clear that it was going to have a good progression-free survival, but we didn't know how long. It looked like it was going to be better than alectinib and brigatinib in the first-line setting, but it had more side effects. And so the concept when your time on the drug was potentially still only a fraction of your total lifespan with the disease meant maybe you could play catch-up later. Maybe starting on the more toxic drug just meant more time with side effects for no absolute net gain. If you could go, it's not A versus B, but it's A followed by B versus B, for those who can do algebra in their heads. And these are the side effects of lorlatinib. You know, it's not an easy drug. It puts up your cholesterol, it puts up your triglycerides. It makes your weight go up, which is a cumulative effect. The longer you're on it, the more your weight will go up. In this relatively early study, something like 20% of patients will put on 20% of their body weight. That's Chris Pratt in reverse. The other thing we worry about is the psychological side effects. It can mess up your mood, your memory, your thinking. You'll have rage episodes. And some who you might all know, but I'm going to keep her anonymous, that an ALK patient advocate said to me, I think lorlatinib should come with a prescription for a psychologist. And so if we go back to the Crown study and we say, well, you know, why are people talking about it? And the simple reason is, at 5 years, when something like 60% of people haven't progressed, you start to realize that this is not a catch-upable situation. This is not A followed by B is the same as B. B seems to be the way of having most people in that plateau up front, but lorlatinib hasn't suddenly become a better tolerated drug. I personally believe its starting dose is wrong. Starting dose is 100 milligrams. Pfizer is, can I just be honest, somewhat screwed because they've got their drug license with a starting dose of 100 milligrams, so they can't tell you anything else. Most of my colleagues, we'll see what they say when we're on the panel, start at 75 milligrams. I actually start at 50 milligrams, and I probably escalate maybe every 2 months because it takes a while for the side effects to manifest. The other thing about this, so I think they really need to study looking at the starting dose. The other thing is physicians need to realize this is a harder drug, and they need to look for those hard-to-see toxicities, the hidden pictures. The rate of CNS effects in the clinical trial was about 20%. When Jessica Lynn and her group at Mass General studied it, it was about 60%. If you don't know the questions to ask, and you don't know who to ask, so if I ask Kirk's wife, I'll get a very different story about his psychological state than if I ask Kirk. Not pointing any fingers here. And again, you know, things like the weight gain is cumulative. One of the things that really drives me crazy is people will show an updated data set and they'll say something like, no new safety signals. And you go, okay, but did the proportion of people getting your same safety signals change? And they go, well, I'm not telling you that. So here is cumulative weight gain. This is going to be shown at World Conference on Lung Cancer, and there's a paper in preparation. It is real with all ALK inhibitors. It's most pronounced with alectinib and very dramatically pronounced with lorlatinib. The time to maximum weight gain is a long time, nearly 2 years. And that's probably only with about 2 years follow-up. I actually think it will continue thereafter. So 13% of people, the average weight gain for lorlatinib is about 13% of your body weight. The proportion of people with grade 3, that's 20% or more of your body weight, is 30% in our study here. It's real. The great thing is, we now have weight loss drugs. This is not a kind of like, oh, what do we do about it? It's like there need to be studies of combining this with weight loss drugs prophylactically and in response to people who are already put on weight. The other thing I want you to start to really focus on is taking a good grip on efficacy and toxicity facts. This is where you really come into your own as patients. So you have choices. To make those choices between treatments, you want to know the efficacy and toxicity information about the treatment. Variation in reporting practices, like what percentage of events have to occur before I show them in my table. I'm not showing anything that didn't occur in more than 10% of people, sometimes 30% of people. Like 1 in 3 people had an event, but I'm not going to tell you about it. Calling events different names, like everyone in the room goes colorblind, so 100% colorblindness. But if I now call it red colorblindness, and blue colorblindness, and yellow colorblindness, and I put my cap at 30%, now nobody's got colorblindness. The other thing we're starting to look at is what's called ISJETs. This is the first time I've said this in public. Investigator-based subjective or judgmental efficacy and toxicity reporting. And that certainly is something we can also fix. So this is from Charles Dickens' classic movie, RoboCop. And the guy there is going, don't worry, my doctor says the side effects are tolerable. So subjective when someone uses terms like tolerable, acceptable, favorable, when they're not the one experiencing them. So this is from ASCO 2024. The number of early stage studies involving lung cancer patients that didn't use a judgmental term was 12%. Everyone else is, the investigator is telling you how your side effects are. But it's not just the investigators. Our toxicity grading system is broken. CTCAE, Common Terminology Criteria for Adverse Events, is what we all use. That's the grade 1, 2, 3. But we tend to bundle together grade 1 and grade 2 because this comes from a stage of short-term chemotherapy where we worry about something really bad happening in a short period of time. We're talking about being on these treatments for years and bundling together grade 1 and grade 2, as you can see in this figure here. Number of patients with grades 1 and 2 are combined. But they're not the same. This is diarrhea. I had great fun doing a poop calculation here. So look at the figure here. Let's imagine that you're working full-time and you normally have 1 poop a day. Grade 1 could be 1 extra poop that you have at the end of the day. Grade 2 is 7 extra poops, which, assuming that you're asleep for 8 hours a day, means you're pooping every 2.25 hours. How are these the same? In that same ASCO 2024, grade 1 and 2 were separated out in only 12% of trials in lung cancer. This is something you can work on. Don't be such a baby, Jim. It's only grade 2. This is grade 2 peripheral edema. So we can push for changes in how toxicity is reported. We tend to only report peak toxicity, but what I want to know about the peak toxicity is how long does it last? Do I have a bad quarter of an hour and everything else is good? Or is it, awful forever? There's nothing on the time it takes to onset. Am I going to be good for the first week, the first year, whatever? And nothing on, as I said, nothing on the duration of the individual grade. What we really want to know, I suspect, is in 6 months' time or this time next year, will I, the patient, be able to work full-time? Will I be able to socialize? Will I be able to travel? Will I be able to run a 5K? Will I be able to have a baby? This is the reality of ALK. Patient on the left conceived and carried a baby on alectinib. On the right, Matt had banked his sperm before starting on anything very wise. He was actually on lorlatinib and again was able to have a baby. This is next generation sequencing. This is what it really means in ALK. And one of the things we have to realize is that these drugs are different. Just because you can carry a baby on alectinib doesn't mean you can carry it on lorlatinib. Will that influence our first-line treatment choice depending on where you are in your reproductive life? Maybe. And we're very lucky that Najus Flores is here, and she really took this and is running with it and now has an international registry of pregnancy. So to summarize, diversity is not our friend in this context. Approaches to minimize diversity include better drugs, consolidation chemotherapy, and radiation, catching oligoprogression. Studies on persister cells are going to be the near future. Studies on immune therapy, same thing. Studies on why pemetrexed are really needed. It may not just be about the cancer in decision making. We are here in a room full of survivors, and that means we have to think about tolerability, cumulative side effects, even low-grade side effects. Toxicity reporting allowing subjective descriptions has to stop. The aspirational goal should be to achieve perfect control of cancer with perfect quality of life. You are all part of this historic journey of discovery to do that, because hope has a face and it's yours. Thank you.